So I really enjoyed the presentations this morning. And one of the reasons why I find it very interesting coming to these different fora over the years is because it has a good mix of both technicians and policymakers. And this morning you got a combination of both. And the minister giving you a very good outlay, a very good discussion about some of the challenges that he experienced from a policy perspective. And I remember sitting with Dr. Joseph when we were talking about the minister's presentation, and a couple of the key themes that we actually spoke about was about the environment, the political environment, the social environment within which we were implementing these changes or responses to COVID, and how difficult it actually was in order to do that in a setting that was not the best. Yes. The presentation by the Deputy Governor from the Central Bank as well was instructive in and of itself, because it actually blended both, giving us some sense that we don't exist in a vacuum. There are external forces that are impacting on us, but at the same time we are eking out our existence by trying to survive within a changing global environment that sometimes do not look too kindly on us. And then the last presentation from our colleague from the Cayman Islands, I paying attention to some extent, because it gives us some sense of some of the challenges he's experiencing while implementing their version of a national health insurance. And it's where we're looking to go. Medical benefit scheme started back in 1978, and the wisdom of the policymakers at the time, the politicians, to get us a system of that nature back then, it challenges me, because I look at this and I wasn't sure that we were thinking, or I'm surprised that back then they were thinking about these things. So I will do my presentation now, giving you some sense of what happens at the medical benefit scheme, how long we've been here, what we're looking to do, some of our challenges as we move on, and then we will have hopefully some questions that can actually tease out some of the information. My presentation, we will look at MBS organizational overview. We will also look at the major objectives and some of the service overview from MBS, funding mechanism, expanded mandate of MBS, some of the challenges, policy responses, and look at where we are in terms of our transformation to universal health care using the vehicle of the national health insurance as appropriate. So, MBS started by an Act of Parliament in 1978. It is a statutory healthcare organization, and there have been some adjustments to the legislation over the years. The major one being the most recent act being that of 2010 was there, where there were some significant changes to the structure of MBS. And accompanying that were the legislations that were passed in 2011 that actually governed the administration of MBS. Essentially, some of the main objective of MBS is really managing and preventing chronic diseases. That initially were actually where we started. We started then with 8 NCDs, and we're now up to 11 different NCDs, which would include the usual suspects that we've been speaking about: hypertension, diabetes, the many forms of cancer that we spoke about, cardiovascular diseases, and so on and so forth. In addition to that, we do some bit of providing financial and other assistance towards the cost of medical service. And we do so and we also use a proactive approach in terms of preventing diseases. This morning you heard most of this speak about the importance of doing this early, getting into educational system, doing preventative care by changing people's mind and attitude. But we also do some of that later on in life, because we do have pharmacies, we have a prevention department, we have a nutrition department, and they actively engage with the public on matters of improving their lifestyles. The medical benefit schemes also provide service as it relates to refunds for hospitalization, surgical care, laboratory tests and investigations, doctors' fees, overseas treatment. Minister mentioned that earlier. This is done at the level of the board. And as well, we do have 6 pharmacies, and they primarily look at procuring and dispensing NCD's medication. Now, one of the comments that I just heard from Dr. Christian, I found it to be quite strange within the context. I know he has been a doctor for some time, but it seems that he's probably not clear on the way in which the formulary for medical benefit is actually established. This is widespread consultation with the doctors in Antigua and Barbuda, and it's a combination of both generic and branded products. And it is done. In fact, we did a consultation last year, I think, Mr. Boville, and there's a new structure around it. Doctors looking at what are some of the cutting-edge medication that are there, what they would add, what they would subtract, and there is the ability for doctors to share with us, give us information about new drugs that they see that we could add to the formulary, and this is done at the board. So I'm a little confused about the comments that he has there, but just note that, again, as the Minister said, it's broad consultation. We're happy to engage in terms of any questions, any concerns you would have, and certainly to add that to the whole list and the whole process of us improving and strengthening the formulary. Let's look briefly at the funding mechanism for medical benefits. We do have a multi-tiered structure. Individuals between the age of 16 and 60 are required to pay 3.5%, and their employers, as long as they're part of formal type employment, to pay a total of 7%, 3.5% from the employee, 3.5% from the employer. Self-employed individuals, we actually received 5% from them based on a notional indication of whatever their monthly salary would actually be. There's also a mandatory requirement for the ages between 60 and 70, if you're still working, to pay 2.5%. And then there is also voluntary contributions at a maximum of 3.5%. And they are the assets of the investment, of the scheme, which are invested over time, and we do get some returns from them. And that together gives us the funding source for the medical benefits. In doing the presentation this morning, I thought about another thing. And Minister, this is something that we could actually consider in terms of our move to the national health insurance and how we bridge this gap. Not a large one based on the report that we have so far, but we just changed the legislation to have to increase the retirement age to 65. Our current act actually speaks to contribution ending at 60. If people are still actively working, we could then extend that to 65. Both the employer and the employee can be paying up to the age 65. So that, along with the point you made about the sugar-sweetened beverages, should probably give us a good flow that we could add to the pile. I don't think it's in the calculation. No, Dr. Lalta, is it? And if we put that in the calculation, I think we would probably be very close to where we need to be in terms of the funding. Let us also talk about the expanded mandate of MBS. Under Minister leadership, you've heard how he has been quite passionate about the healthcare system, how we engage, ensuring that there is sufficient resources to ensure that no one has a challenge accessing healthcare. And that being the case, over time we have had additional requests through the government, through the ministry, to expand the role of MBS. And two in particular that I would like to speak about is, I think back in 2017, the MBS was mandated to manage and procure all pharmaceuticals and medical supplies on behalf of the entire healthcare system. That is a process that we're doing now. It is efficient. There's a similar process with respect to the hospital as well, in terms of what the formulary looks like. In addition to that, we have these bilateral arrangements that we have with some service providers. We initially had one with Health City Cayman when we had some doctors coming doing some work on the orthopedics. We now have one with the Trinidad Eye Care Hospital, where we have doctors coming up for a week at a time to provide that type of service that otherwise would have been significantly more expensive if individuals are to go to Trinidad to actually access these services. You can well imagine that the cost associated with families traveling to get this service done. They were here last week, and I think they did a total of in excess of 100 surgeries. There was one gentleman in particular who has been blind for the last 4 years. Minister Adolf, I'm not sure if they shared that video. They showed me the video of this individual who was blind for last 4 years, and after doing the surgery in one of his eyes, he was able to see, and the reaction from him. This is the type of work that we do in trying to bring services to the different beneficiaries and allow the service to be accessed locally. There was a general theme coming through: small countries, small size, we cannot pay for everything, we understand that. But we have to try to find innovative ways of actually going and looking at these things and bringing the healthcare to the individuals that we meant to serve. So what does the expenditure for medical benefits look like? And the diagram will give you a general sense of how the contributions are dispersed. Contributions to the Ministry of Health, almost 50%, which includes infrastructure costs for the hospital, some of the payments that I spoke about in terms of the bilateral agreements, the pharmacy, and the amount of drugs that we procure for NCDs. But we're having this ongoing conversation about what that number should look like. In the budget as well is a portion for preventative care as it relates to our prevention unit, our new nutrition unit, and the kind of activities that they put out, starting in the schools. Recently, we had a childhood obesity project that we engaged with one of our social partners, and we were able to go into 6 schools over a 6-week period and engage not only the kids but their families in terms of healthy lifestyle, engaging the coaches with exercise within the school, doing testing and identifying the kids that are at higher risk for obesity, and as well to implement the process of providing vouchers for vegetables to the parents to allow them and train them in that entire process of eating healthy. So this is something that is ongoing. That was a smaller project within a wider scale, and Minister mentioned that the ministry is looking at, and we did this not only with MBS, but we incorporate resources from the ministry and other service organizations to ensure that we are all on the same page in terms of how we engage, how we roll out these programs, because the overall goal is to do that much more widely. Let's look at some of the challenges that we have experienced over the years. We have had some issues of inefficient procurement processes. One of the reasons why the minister at that time actually turned the management of the Antigua and Barbuda Central Medical Stores over to MBS. And the whole notion about the formulary, the structure around that, the structure around our entire procurement process, they are quite rigid. And we actually do that to try to reduce the amount that we're actually spending. No system is perfect. There's still room to look at this even further, but we're actively trying to engage in order to bring the cost of these things down. We have seen this, and particularly during the pandemic, we had operational deficits, not only at MBS, but at the Mount St. John, Celeste Bird Medical Center. And these are things that we have to manage actively. With the strong support of the ministry and with the government, we were able to come through a number of these challenges, and we now see a return of the funds. I think right now our funding is actually back to pre-crisis levels, and it's providing much more comfort in terms of how we actually do these things. Another one that I would categorize as unclear relationships between the MBS, the hospital, MBS, the Ministry of Finance, MBS, and the ministry. And the presentation by our colleague from Cayman, I think he actually referenced some of these things. And one of the reasons why it's important to be here is to understand how we clarify a number of these things. The whole notion of moving to a national health insurance is to ensure that we have some structure around these relationships. Doctors, how they claim, who claims, how much, what's the purpose. The deductible, the one that we got caution about this morning, that the efficiency of the service will be such that we need to ensure that people are making a contribution, but to balance that carefully to ensure that it does not prevent access. Benefits packages expanding without appropriately looking at the cost for that. We have seen that as well. in terms of our diagnostics and our imagery services being done at the hospital. What is the cost? What is the refund? Is it matched against what we receive? These are all things that we need to look at that are preventing some challenges now. So yesterday when the chairman spoke, he referenced a couple of points. And the sum total of his comments was that the government has an overall policy of how to treat healthcare in Antigua. They are on board on the universal health care and or universal health coverage and how we're going to get there. And this is enshrined in the work plan of the Ministry of Health, as well as the strategic objective that the ministry have actually pushed out. In particular, the strategic vision for the ministry, based on its 2016 ODA, was to attain optimal health and wellness for all residents. In addition to that strategic objective, to increase financial resources to health by 25% through innovative financing mechanisms, some of which we discussed, and we just found 2 loopholes that we could probably exploit right there to increase our numbers. As well, to ensure that the Ministry of Health continues to be the key player, leader in terms of this transformation that we're actually looking at. And we can go through some of the benefits and so on of medical benefit, but of the NHI. But I'm sure some of the speakers spoke about that. But what I want to talk about now is what we're looking at and the structure of the transformation that we want to look at. This is the one. So we have been working with the University of West Indies Health Economics Unit, and we've been doing so for some time. As the minister mentioned and the chairman mentioned yesterday, this work would have been completed. The minister had initially given us a target date of the end of 2020 to implement. But COVID, in the middle of this, university consultants were called back, and we certainly had to pause. In fact, as is the case globally, COVID essentially took the air out of the room, and most of the effort and the resources were directed to responding to COVID. But this is the structure that we initially spoke about. It's through the Ministry of Health. We do have established a steering committee that is broad-based. Minister ensured that that was the case, that we had wide consultation about what this new structure, what this new arrangement would actually look like. There is a steering committee, and this, again, there's stakeholder consultation in there, but in particular, there are a couple pillars that we want to look at in terms of rolling out universal health care. There is the legislative framework that needs to be adjusted. We now have maybe about 10 pieces of legislation that govern activities within the healthcare sector. We need to ensure that they are coordinated well, that there is vertical and horizontal integration, or even pulling them under one central piece of legislation. We have to look at the benefits packages. What are we looking at? There's some challenges that we had there in terms of cost, benefits, what is being refunded for expenditure. Our colleague from Cayman spoke about the cost setting, where the cost was $250. The law says you get $150, but the doctor's charge. So all these things that we need to look at. The governance structure, what this would look like. As it is now, we do have medical benefit scheme. The minister's vision is to have the NHI being a subset of that coming out of the medical benefit scheme. The business planning processes. We have had some of the technical work completed on this already. We certainly have macroeconomic environment. We've spoken about that, although that is likely changing now. And we do need to look at that again to ensure that the environment that we contemplated back in 2019 continues to hold as the foundation within which we're rolling out this policy, which has cost implication. The revenues that we get is a function of the activities that are taking place within the economy. We saw that during COVID when that declined significantly by about 25%, and we had to be managing within that process. We do have the completed technical work on the benefits package, what it should look like. The funding arrangement back in 2019, of course, now we need to look at that a bit more to see how it can be tweaked. What is missing, though, is this notion about how it would work. And one of the reasons why this discussion is actually very important. We are still toying with this. The technical work has not been completed as yet, but we see this as the role of clarifying the relationships that we spoke about, trying to ensure that the relationship between the doctors who are providing the service providers or the laboratory services, consistent with some structure, some service agreement with MBS. How do we engage with the hospital? How do we engage with the ministry? And this is to some extent what we are looking at. We're looking at several models. Some of the discussion that we have here will be useful in terms of informing that process. But as soon as we engage again, and we are in the process of doing that, this would be the next piece that we're working at. We started some initial work on this, looking at the IT infrastructure that exists now. When the team was here, they went to speak to some of the doctors, some of the laboratories, understanding what their structure looked like, what their IT platform looked like, what kind of internet connection they have, how could our system tie into their system, how can our system tie into the hospital. So these are the things that we're looking at now, and this would be a very key piece of this. I mean, this as well as the legislative framework that we actually look at. So the funding we're looking at, we have completed most of that. The benefits package, we've completed most of that. The governance structure, we have looked at that as well. We have completed that. The operational framework is what is the next big thing that we need to look at, and that will actually take some time for us to look at. Just to give you a sense of where we are and what this thing looks like. We're hoping to transform medical benefit, but the question is, after 45 years of existence and changes within this environment, what do we have now, and how far do we have to go to get to this national health insurance that we're talking about? And interestingly, we did an assessment based on the WHO and the Health Economics Unit survey on universal health care in Antigua and Barbuda, and we're using the health financing policy matrix. And what we found that in our present structure, out of a scale of 1 to 10, we actually was just about 7 out of 10 in terms of what we have now, meaning that we need to go another 31% to get to national health insurance. And if you just see the slide where this is essentially what it looks like in graphical form. Based on our structure now, we do have more work to do. We have work to do in terms of the amount of people that are covered. We have work to do in terms of the kind of service that we want to provide. Minister in particular is very excited about providing about cardiac service, about the transplant, other things. But it's, how do we do it? Do we bring it on island? Do we do a consultation, some kind of exploration? How do we do that? Because part of this would have to be wrapped into the cost and the structure of how we want to do this. All right, so this is my final slide. I will leave you with this. Essentially, after 45 years, this is essentially what we look like. This is how much we need to go. There is much work to be done, but we do have a structure, and what we're hoping to do is to quickly make the necessary changes to not only the legislative framework, but our infrastructure to ensure that we actually get there. Thank you very much for your time.